Greetings, everybody. First and foremost, I have a question that I must ask you, but we've got a Robjob Rapid review, so I'll shave it for later. So let's just dive on in here. Here we go, another Robjob Rapid review. Today's topic that we are covering is acute coronary pharmacology. Before we dive into the pharmacology, let's just establish some details. Here we are talking about unstable angina, non-ST elevated myocardial infarction, and ST elevated myocardial infarction. Those terms are really long. They need an EKG. Nobody will know what it means. To the layman, we are dealing with a heart attack. One of the biggest killers in the United States. It's a super important topic, and this is going to present in every single clinic. This is pervasive. With that said, everybody, let's dive in. So unstable angina, the first thing is this is partial occlusion, where with the ST elevated MI here on the bottom, this will be more than 80% occluded. So that coronary artery will have more than 80% blockage, and STEMI will have less than 80% or the unstable angina. The big thing distinguishing between the unstable angina and the NSTEMI is that you're going to have elevated troponin in the NSTEMI, and you're not going to have elevated troponin in the unstable angina. Troponin is just a molecule that's released when the heart is contracting a lot. It's composed of 3 regulatory molecules. And in the context of NSTEMI and STEMI, this is elevated. When we look at acute pharmaceutical treatment, the first thing that you're probably going to do is you're going to throw them on dual antiplatelet therapy. This is a combination of aspirin and then another antiplatelet, which is typically Clopidogrel. Heparin can be used if they're high risk, and then we can also use nitroglycerin or beta blockers to control that angina. On the other side of things, when we're dealing with a ST elevated myocardial infarction with elevated troponin, we can use all those same things, but the other thing that we can use is we can also use a thrombolytic if this patient is greater than 120 minutes to the nearest healthcare center. The reason why we do that is because if we're less than 120 minutes, we don't want to use a thrombolytic because they could be sent into the cath lab, or they can get a percutaneous coronary intervention. When we look at the long-term management of these diseases, they're going to get a cocktail of drugs. Typically, they're going to get that antiplatelet, they're going to get a statin, they're going to get an ACE inhibitor, and they're going to be on a beta blocker. If patients are presenting with acute coronary syndrome, one of these 3, they're going to be on a lot of medications to get that under control and to prevent the onset of another myocardial infarction. One word that I kind of just tossed out there is dual antiplatelet therapy. You're going to see this a lot. This is essentially just attacking the platelets with 2 drugs, and typically that's aspirin and that's Clopidogrel. So just keep that in mind. So here we are diving into the pharmacology here with fun mnemonics that might work for you, but dang, they're working for me. So first one, anticoagulants. This is heparin. Heparin is used, the mechanism of action for heparin is it inhibits the thrombin through antithrombin 3 complex. And then the other anticoagulant that we can use is enoxaparin. So there's heparin and enoxaparin, the mnemonic, no pairing of the platelet. What this does is this inhibits platelet formation, so it decreases the chance of a blood clot or clotting there, so we won't have an infarct. And the side effect for these is just bleeding. And then heparin-induced thrombocytopenia is also something to be mindful of. So beyond the anticoagulants, now we're going to the antiplatelets. The first one is acetylsalicylic acid. Let's just call this aspirin. We all know what aspirin is. No need for a mnemonic. Aspirin, aspirin, aspirin. We've seen it. We've probably taken it. What this does is this irreversibly binds to the COX-1 enzyme, and it inhibits platelet aggregation. For all the antiplatelets, we are concerned about bleeding. The second hitter on the list for an antiplatelet is Clopidogrel. This is typically what's used with that dual antiplatelet therapy that I was talking about earlier. The mnemonic is close the platelets. It's 2012. Close the platelets. It's 2012. Why did we say 2012? Because Clopidogrel inhibits the P2Y12 receptor. This is metabolized in the liver, and this also inhibits platelet aggregation. And then the last one is a drug that is not commonly used, but it is so fun to say. On 3, let's say it, Epitifibitide. Epitifibitide. What does that sound like? The epic tide. We've got a wave coming to shore. a tsunami. Is it a category 2 or is it a category 3? I'm not sure, but the mnemonic is Epitide for Epitifibitide. And this blocks the GP2B3A. What this does is this essentially inhibits the formation of fibrin, which attaches the platelets together. So what this is it's an anti-platelet. It inhibits platelets. What are we looking out for? We're looking out for bleeding. So those are the first two. Anti-coags and anti-platelets are going to be part of your regimen when treating patients with an infarct or unstable angina. Now, thrombolytics. Thrombolytics are a huge category of drugs, especially when your patient is having an acute myocardial infarction and they can't get themselves to a primary care center. We're going to use thrombolytics to break up that clot. The mnemonic is ACE the clot, like the volleyball spike. You're going to explode it. It's going to be removed. And how we're doing this is we're doing this through streptokinase and alteplase. ACE the clot. Alteplase, the mechanism of action is it converts plasmin to plasminogen, and then the mechanism of action for streptokinase is it activates plasmin by cleaving the bond in plasminogen. So just keep plasmin to plasminogen in your mind. It activates that process. It dissolves the clot, and it is used in the context of a STEMI. These are also a huge risk for bleeding, huge risk. That's why you don't want to use them unless you absolutely have to, and be mindful for cerebral hemorrhage for the thrombolytics. We're back to our beta blockers. We're eating a garlic aioli sandwich. Alol, Ilol, Olol, Olol. The first two are Labetalol, Carvedilol. These also decrease the heart rate and contractility. We've talked about these ad nauseum. The other one to keep in mind is Metroprolol, and that's the beta-1 antagonist. Again, Alol, Ilol, it's the first ones. These are the most specific. They're going to specifically attack the alpha-1 and beta receptor. And then the second one is not as specific. It's just going to be the beta-1 antagonist. These two drugs are used to treat angina. So if that patient is experiencing angina in the ER, we can give them a beta blocker, and that typically alleviates that acute pain. Another thing that we can use is calcium channel blockers. These aren't used as common, but they can be used. These vasodilate, these decrease afterload and preload, which then will alleviate angina. We've got some fun mnemonics here, folks. First one, I love dill pickles. Dill pickles, Diltiazem. We use this. It's a cardioselective L-type calcium channel blocker, and we will use this to alleviate angina in particular cases. And then the other one is Amlodipine. I am loading blood in the vessels. We're getting vasodilatation. We're decreasing afterload. We're decreasing preload, and therefore we are decreasing angina. The other anti-angina, and probably the most common thing that we will be using, is nitroglycerin. Super potent. It's endogenously released naturally, but we also have this as a drug to increase that response. We get massive vasodilatation, and we don't have a mnemonic because it's nitroglycerin. We all know what it is, just like we know what aspirin is, correct? And guys, that's pretty much it. Those are the 5 family categories of drugs that you're going to be using. I'm just going to throw in a couple late hitters here that you may see. One is Ranolazine. Ranolazine? I don't even know if I can say it, but we ran out of sodium. It's a sodium current inhibitor. It inhibits late entry of sodium. So just think Ranolazine ran out of sodium. This is usually treated in rare cases for treatment-resistant angina, and just be aware of hypotension in this case. And then the last one is Ivabradine. Ivabradine is a funny channel inhibitor. The mnemonic for Ivabradine is the Brady Bunch, because that show, at least I heard from my grandfather, because I've never seen the Brady Bunch, is freaking hilarious. So the mnemonic is Brady Bunch, Ivabradine. We're inhibiting the family channels because the Brady Bunch, I'm sorry, Grandpa, is not that funny. So anyways, guys, that's another Robjob Rapid review of acute coronary pharmacology. Just keep in mind that these are used in the context of 3 types of acute coronary syndrome. We got the unstable angina, no troponin. We got the non-ST elevated myocardial infarction. There's elevated troponin, but partial occlusion. And then when we've got more than 80% occlusion, we are seeing our stereotypical myocardial infarction with ST elevation. And that's where we're going to use the cocktail of drugs that we talked about a priori. I think that's it. Over and out. Robjob. Here we are. Thank you so much.